Welcome, everyone, to day 2 of charting your path, the QI series, all about the science of healthcare improvement. Today, we're going to talk about PDSAs, or Plan, Do, Study, Act cycles, which are often referred to as the heart of improvement. And we'll touch a little bit on data, your performance enhancer. Hopefully I won't put you to sleep. It can be a bit of a challenging topic. I'll try not to get too nerdy about data, but let's go to the next slide. So if folks know by now the routine, put your name, role, and organization in the chat. And if there's one thing that you hope to come away with or learn today, put that in chat, because we want to make sure that we touch on that. And I'm going to move on to the next slide, but Maria is going to launch a Zoom poll asking you what your PDSA know-how or expertise is. Do you feel as though you're an expert PDSA Jedi Master, or are you intermediate, or are you a novice, like I mentioned yesterday that I was, and I couldn't even remember what PDSA stands for. Just let us know where you would put yourself on your PDSA expertise or know-how. All right, and while folks are putting their names, roles, and orgs in chat, let's go ahead and move our slides forward. So we have a lot to cover today. So Confucius was so wise, and I love this saying that learning without reflection is a waste, and reflection without learning is dangerous. Now, I'm not sure that I would call it dangerous if we don't reflect on yesterday and learn something, but just kind of taking a look back at yesterday to kind of ground us in what we're going to cover today. Let's go to the next slide. So our reflection is, we really want over this QI series for you to gain new strategies and skills to build your quality improvement acumen, or sometimes I call it your QI IQ. But if this environment of learning doesn't quite work for you, or you need a deeper dive, we are here for you. And if you want a one-on-one with the same information, or you want a one-on-one or with your organization to see, well, okay, that's great, Trudy, like you really kind of covered the kind of glossed over this, but how does it really relate to me as a community supports provider, or as an enhanced care manager, or an organization that's providing both of them? If we're not really going to super duper build your skills and strategy in 3 hours of trainings. As I mentioned, these trainings are often many hours long, and with feedback and helping people with the tools. So just, if you need more of this and you want this on a more personal basis, we're here for you, even if it is just to take our slides and build your own training around it, if you want some help on messaging for each of the slides or something like that. So we talked about the 4 elements of the model for improvement. What are we trying to accomplish? What the heck is it we're even trying to do? And around that first question, what are we trying to accomplish, are your aim statements. And then how will we know that a change is an improvement? As one of my beloved colleagues, Regina Neal, always says, you can't just throw spaghetti up against a wall and see what sticks. So how will we know that a change is an improvement? We measure, and there are like lots and lots of ways to measure. And as I said yesterday, we were going to dive a little bit more into that. And then what changes can we make that will result in improvement? So that's kind of brainstorming, and what are the ideas that we can come up with? And then you test those ideas, and using the terminology from DHCS and others, it's calling it a test of change. So we test that change, and we do that using Plan, Do, Study, Act cycles. And then yesterday, we also talked a little bit about like, how do you identify what those opportunities to improve are? Sometimes it's just observing a process and saying, wow, that is really inefficient, or, we can do better. And on our one-on-ones with doing our listening sessions, we said, how do you get feedback from your system? Because remember, every system is perfectly designed to achieve the results that it gets, that number one principle that we talked about yesterday. And it's really impressive how people are identifying opportunities to improve, doing their own intuitive PDSAs on the fly, and improving our system. So let's move on to our next slide and what we're going to do. So building skill in planning and executing plan, do, study, act cycles, or PDSAs. I talked yesterday about purposeful practice, and very, very early on, I told you I went from being, I don't even know what PDSA stands for, to developing trainings, working with organizations to coach them around PDSAs. And at the organization that I worked at for 11 years, a nonprofit quality improvement organization, we had a lot of other consultants, and we had to practice PDSAs. It really requires some practice. We will take a look at what some of the common PDSA pitfalls are, and that is bringing to bear our experience with what the pitfalls are. There's a number of them, and you just want to make sure that you know what the pitfalls are so that you avoid them and make your PDSA journey just a little less fraught with danger, let's say. And then we'll dive into data. And as I said, I'm hoping that I don't put you to sleep when we talk about data, and then we'll talk a little bit about how best to use it to drive improvements. So let's go to our next slide. And you remember that yesterday I said that improvement is really, it's what we humans do. It's just, this is what we do. It's intuitive. We're always trying to improve things. It's probably why we're one of the most successful species on the planet. And, back in the day, back before, I don't know, maybe it was the Stone Age, these two Neanderthal folks got together and they're like, it would really be awesome if we could have fire. So let's see. So they did their plan, and they said, let's take two fish, let's rub them together, see what happens. So they did the do part. They rubbed those fish together as fast and as hard as they could, but nothing. It was fishy, smelly. There's scales all over the place. They had to wash their hands. It was just a mess. So they kind of studied their data, and they said, this isn't going to work. And then they did the A part, which is they either adopt it, like, oh my gosh, this is the best thing. They abandon it, like, whose crazy idea was it to rub two fish together? Or they adapt it. And so they adapted it, and they said, well, hey, let's try rubbing two sticks together, and voila, we had fire. And so began the success of the Homo sapiens. But it's no different. I mean, you do this all the time, and we shouldn't be intimidated or because we don't know, what the word PDSA is, because intuitively you do know what it is. And so the plan part is figuring out the questions that we want to answer. Whenever I'm working with a clinic or an organization, they say, well, we want to try this thing and see what happens. And I'm like, well, what's the question that you're trying to answer? It could be, are patients taking their medications? And then make predictions. So if we make this change, what do we think will happen? And that's part of what you come back to for your study part. So, we made the predictions, is that what happened, or did something else happen? And sometimes when you implement a change and you think things are going to go horribly, and that's your prediction, like, oh, the clinicians are going to hate this, they're not going to do it, you end up being pleasantly surprised. So then in the plan part, you outline the plan, which those three words sound really innocent, and it's short, but it can take a bit of effort. And when you do the plan, include how you will collect data. So if you're center is, you're trying to sort out like, how can we make our call center more efficient? It might just be like collecting the data might just be a steno pad and you're, doing hash marks. It doesn't have to be something fancy. And often organizations will say, but we don't have an electronic health record that can run that report. It doesn't have to be that kind of fancy or high tech. And then do one small test of change. You think, oh my gosh, this is like this amazing change. Let's just do it organization wide. It's a good idea to test it on a small scale, maybe one call center receptionist, or one clinic, and then you would try to expand it. So then you do it. So what's the do part? Just do it, do the plan and collect data along the way and then study it. What did we learn? And then the act part is, what are we going to do with what we learned? Are we going to adapt it, adopt it, or abandon it? I should probably call it the PDS AAA because you act and it's those three. And if we adopt it, what's the sustainability plan? So I often see organizations say, oh, this is great, we're going to adopt this, but then they don't build it into policies and procedures and make sure that it's sustainable. So it seems like a simple matter to do a PDSA, say, wow, this is great, we're going to implement this change. But there's a statistic from McKinsey Consulting that only 30% of change actually sticks. And I would say it's actually less than that. Maybe in healthcare, it's less than 30% sticks. So what are you going to do to, oh, I'm sorry, Maria, I'm actually on the next slide. If you're going to adopt it, what is the sustainability plan? And do we need to test under different conditions? So you may have a place where meals are being put together in one organization or one area of a building, and then just making sure that if you implement a change, that the change is it works with different people, with different teams and different locations, because it can just be very, very different from one condition to the next. Okay, let's go to the next slide. So here's the PDSA pitfalls, and this is I sometimes call it the kind of my list of things that I've learned along the way. So in this slide, you've got it all, everything I know about what not to do with PDSAs. So it is a skill. People think, oh gosh, yeah, great, I got PDSAs, but it's a skill, it's not a project plan, and it requires data. So it's a skill. You need to build your skill in drafting PDSA, so writing them out, even if it's on the back of a napkin. It doesn't have to be on a fancy form. Just work at it. And I'll often say that if you see someone put one together and then you do one on your own and then you teach one, that is the best way to know that you have this down as a skill. So the see one, do one, teach one philosophy is a really great way to know that your skill is, you're really skilled. And don't expect staff to know how to do this immediately. What I see some of my FQHCs do, because they have been doing quality improvement for many, many years, is they just tell staff, hey, if you want to try something new, just do a PDSA. And frontline staff don't always know that. So a medical assistant who hasn't gone through any QI training, or reception staff, they're like, I don't even know what you're talking about. So don't expect staff to know how to do it. And it has to be, you have to hit the easy button for them. A lot of my FQHCs will keep track of their PDSAs, and to do that, they'll say, well, if you want to do a PDSA, go online, fill out this form, submit it to the QI committee. You know what? Staff have already moved on and are on to the next thing. And it has to be really easy if you're going to involve staff in PDSAs. And so just don't expect staff to know how to do this immediately. And it's not a project plan. So not ordinarily. So you can use the PDSA format for a project plan. It makes total sense. But when you're doing tests of change, it's usually just one test of change. And you're testing it on a small scale, and data collection should not take months. So I'll have some of my organizations say, okay, we're going to try this change and we're going to collect data for 6 months. I'm like, no. let's figure out a way that we can do a cycle that's going to take a week or two, because on my next slide, I'll kind of show you a busy slide that sends the message that the faster you do PDSAs, the faster you learn, the faster you learn about your system, and the faster you improve and change your system. So data collection should not take months. It doesn't have to be something fancy. It can be, like I said, hash marks on a steno pad, on a sticky note, and it requires data. Don't just try it and see what happens. Don't take the spaghetti on the wall approach. Collect data if you can. Sometimes you can't, and sometimes data is just checking in with staff and saying, hey, from your standpoint, is this better, worse, or the same? That's data. And deliberately plan how you will measure to know whether the change results in an improvement. So I'm going to pause here and just check in on chat. Are there any questions or chat messages that I need to know about that I haven't seen? Maria, help a girl out.
Hi, Trudy. I'm not seeing any, just folks' introductions in the chat.
Okay,
and
cool.
Also doing a quick sound check. You're sounding great so far.
Thank you so much. All right, let's go to the next slide. So this is a really busy slide, and I always wonder, should I even include it? But it's really a demonstration that bottom line, over on the right-hand side lower, the more PDSAs and the faster you do PDSAs, the faster you learn and the faster you progress to shift your system so that you have the results that you want. And this is from the improvement guide. It's you start with your hunches, theories, and ideas. Remember, we talked about how you identify the opportunities to improve, and then you do your first test, a small test, just one. Then you scale up, you increase time and people. And sometimes the Institute for Healthcare Improvement says start with 1, then go to 5, then 25, 50, 100. Sometimes it doesn't have to take that long. Test under new or different conditions, and then implement the change, spread it, and sustain it. That sustainability piece, as I mentioned, is so hard. And sometimes if you want to sustain the change, it's continuing to measure and giving feedback to your staff. I worked with a organization in Boston, and they implemented a change, and it had to do with patients checking out at the front desk, and they monitored how many times the reception staff were actually using those checkout notes, because they were able to tell, because they had to go into the EHR, eClinical Works, and they kind of tracked it over time, and it started getting lower and lower and lower and lower and lower, and eventually, like, it was only happening a couple times. So they shared the data, and they said, hey guys, look, we started out with, like, you guys are doing great, and look, things are just falling off. And it sent the message to the reception staff that people are looking, people are measuring, and this matters, because if it didn't, they wouldn't be measuring and coming back to us. And they never had to measure again, or, well, they did measure periodically. They just did it once a quarter to make sure they were holding the gains. So the next two slides are to answer a question that I often receive about PDSAs. So let's go to the next slide, Maria, the priority matrix. So how do you know, people say, well, how do I sort out or prioritize PDSAs? Which ones are the most important? And I usually think that the ones that are most important are when you're noticing that there are issues with quality or quality assurance. But I usually put it into if it's impacting efficiency, patient safety, staff, like staff burnout, like, you know, those things kind of bubble to the top for you and you're like, wow, we need to step in because this is just not working. But if you want to kind of prioritize them, you can create your own priority matrix and give it a scale of 1 to 4 if you like. And you could just kind of those headings across the top, you can make up your own categories like our priority scale of whether we're going to test this change is if we're going to get very little pushback, we're going to do it. Or if we don't have to like go to our CEO to ask, this might be a good one to do. So in the realm of you know, community supports and ECM, you know, I tried to come up with an example, and I'm sure you on the phone would come up with much better example. So conduct 1 in-person meeting per week to promote community support. So this is a test of change that we've discussed as a collaborative, doing that academic detailing and going into clinics and talking to the providers, or maybe even better to the MAs or LVNs to promote community supports. And for the enhanced care management, like maybe you're going to implement med boxes for those struggling with meds, and you're going to test it on a small scale. Like let's just try it with 5 and see whether medication adherence improves. And you can kind of give it a scale of 1 to 4. Like is it going to have much impact, or is it very important? I'm not sure. Let's give it a scale. Is it within the span of our control where we don't have to go to you know, CEO to, or, you know, get approval or go ask the alliance, can we do this? Is it easy to implement? Is it cost effective? How quick will it be? And then you can just add them up. And this is just an example of a priority matrix. Like I said, you can add your own. And then kind of the other one that it comes from Institute for Healthcare Improvement. They have one very similar. Let's go to the next slide. Is the risk of the PDSA and the degree that you think it'll work. And so you can put it in a matrix. And if you're not really sure that this test of change is going to succeed, you're kind of like, there's so many things that could go wrong. Like, I don't know, I suppose we could try it. And you also know that if you were to try the test and if it failed, there would be major consequences. You want to test on a very, very, very small scale. So maybe we test with 1, but then, you know, you can see that kind of with a higher degree of belief and success, and a failed test would have minor consequences. Heck yeah, let's just do 1 cycle and maybe we can implement the change. So I did want to touch on those. I hardly ever have to use those. But I always get questions. How do we prioritize? How do we kind of sort out which one we do first, second, third, etc.? So let's go to the next slide. And this is this is a kind of a PDSA worksheet, and we will, when we send out the materials with the slides and a couple of resources, we're going to send out kind of a worksheet for doing PDSAs that we have developed over many, many years. And the first thing is to identify what's the objective for the PDSA. Like, what is it that we're trying to fix? Is it, hey, people just don't know about community support services, or is it patients are not able to remember which medications to take when, and so they just don't take them? And what is it that we're trying to fix? And then I get this question, but what about our aim? So remember back at from yesterday, you have your overarching aim statement. And you don't have to have an aim as part of your PDSA. Your PDSA is supporting what you're trying to accomplish. It's that other question that says, what can we try? What can we, you know, what changes can we make that will result in an improvement? Then you come up with your ideas, and then you test your ideas. This is just testing an idea about change that you think is going to result in an improvement, but you're not quite sure. So let's do a test of change. So don't get hung up about the aim. And I just stuck that question in there. It may not make sense. Like, why is she even talking about what about the aim? I'm putting that there because I just get so many questions about it when we work through a PDSA. So let's go to the next slide. So for the plan, what is the specific change being tested? And I've added this to our worksheet because people get all over the board and they aren't being really deliberate about what is the one thing that we're going to change. What is the specific change that's being tested? And you don't want to have, if you want to know whether a change results in improvement, you need to test one thing at a time. So if you are trying to address medication non-adherence and you do a med box and you provide them written instructions on their medications and you do this other thing, if something improves, you're going to have no idea which one it was. It was just like the wild, wild west. So what is the specific change that we're going to test? We are going to have the RN load the med boxes, or we're going to have the pharmacy load the med boxes, which is a little harder to do, but you can still do it. What are the questions that we have? Like, is this going to work? Are patients going to like it? Are the RNs going to have time to load the med boxes? Do they have the skills? Do they feel confident? Predictions. What do we think is going to happen? Well, we think it's going to make it easier for people to remember what their medications are. And then what's the plan for the change or test? Well, we'll start with, we'll start with the next 5 people that we enter into our ECM program. And, do we know who the care managers are? Like, or maybe we should choose a specific care manager who's very experienced, and we'll use his or her first 5, or have him or her choose 5 patients to start with. Like, what's the plan? Like, how are we going to do it? I really recommend just taking a few minutes to put it out sometimes, to write it out. Sometimes it seems like a really, really easy thing. And then you start kind of typing it and you're like, oh, well, that's not going to work. We need to do this other thing. And then what's the communication plan? So what an organization will do is they'll do a PDSA, but they won't tell anyone else that they're doing it. And someone will see that somebody's doing something different. They're like, what are you doing? Oh, I'm doing a PDSA. So just always make sure that when you're doing your plan, that you have a plan for how you're going to communicate it. Is it going to be at the next staff meeting? You say, hey, we're trying this out to see how it goes. We'll get back to you and let you know. And then the plan for collecting the data. Who's going to collect it? Exactly what are they going to be collecting it? When in the cycle? Where? All these questions end up coming up. So let's go to the next one. So the plan part, as you can see, is like really long. And then we've got, so there's plan, do, study, act. So it's kind of like a lot shorter for the do, study, act part. So the do part is you just do it. Like I said earlier, you collect the data, you start beginning your analysis. Maybe you're checking in with people at the front lines and saying, well, how's it going? And then when you kind of have done it, you study it and you're like, okay, now let's put the data together. Let's check in with, what people said. Let's summarize what was learned. And this doesn't have to be, it sounds a little bit excruciatingly detailed, but it can be kind of on the fly. And then that, I think there's a third time now that I'm saying that the act part is, are we going to adapt, adopt, or abandon the change? And then if we adapt it, like what's the tests of change or plan for the next cycle? We're going to start our next PDSA. If we adopt it, how are we going to spread it? How are we going to make sure we have sustainability? And then if we abandon the change, how do we learn from this and not make the same mistake again? And my organizations often ask me like, okay, Trudy, but how do we keep track of the PDSAs that we've done? Because like we started to implement a change and we're like scratching our heads going, didn't we try this like 2 years ago and discovered that it didn't work? And I don't have a really good solution for that. I think, a Google Drive, or honestly, sometimes just keeping it in a PowerPoint slide or Google Slides to go back to, but I haven't really cracked that nut. So let's go to the next slide. And this is what that form looks like. And we will have this sent out to you. And what we often do when we have more time is I just stop screen sharing and I get one of you to say, hey, what's a change that you want to try? And we just work through this in real time. I do this with my in-person trainings as well. I always feel like a little bit like a deer in headlights, kind of thinking, oh my gosh, what if something happens and I can't get through this? But we end up doing it. But this is the form that if you want to work on a PDSA, we will walk you through. Let's go to the next super duper busy slide. I think this is animated. And this is just kind of a summary of consider the see one, do one approach, as I mentioned. Be clear whether you're using a PDSA as a to test small changes, or whether you're using it as a pilot or a project plan. So are we piloting something? Like, are we rolling this out and we're going to pilot it? Because that's not really a small test of change. Make sure that people are clear on the role of the PDSA and how it relates to the model for improvement. So we've had some discussions internally at HIP about, like, how do PDSAs relate to the model for improvement, and how does all of that relate to driver diagrams? So we are going to have a deeper discussion at some point, and maybe we have a bonus session around driver diagrams. We'll see. Stress the importance of data in the PDSA. So you can't let perfect get in the way of good. And don't be fussy about how you're going to get your data. Remind folks that PDSA should be done on a small scale over a short period of time. Test in several conditions. I think that might be the second or third time I've said that. And help the teams follow through the PDSA through to the A part. So what ends up happening is people draft the plan part, and then they're off and running, and they never come back to go like, well, whatever happened? So try to have the rigor to follow through, and find a way to document your PDSAs for posterity, as I mentioned. And then one of the best ways so yesterday, you may remember I talked about purposeful practice and feedback. I was working with Northeast Valley Community Health Center. I probably don't have their name quite right, but if you know them, you'll know who I'm talking about. They're actually part of the PATH Collaborative as well, in LA. And we did an on-site training, and Deb Rosen, their QI director, had this amazing idea and said, well, let's have everyone put their PDSAs together. And then we met as a group, and everybody read everyone else's PDSAs and gave them feedback. And that was part of that deliberate practice for learning and building skill. So let's go to the next slide, and then move right along onto our next slide about data. And I'm just doing a time check. So we're about half the way through our half hour. So this is the part that I'm really hoping that I don't see everybody leaving our Zoom meeting. And I hope that I don't put you to sleep. So let's go to, so take a sip of your coffee or your Red Bull or whatever, and let's get through data. It's not going to be that bad, I promise. So Gerald Langley is one of the authors of the Improvement Guide, and he says, ultimately, the goal of using data in primary care or community support or enhanced care management is to guide quality improvement. And the challenge is getting enough data to direct improvement activities, but not so much to burden the effort. So I often say that two of the mantras of quality improvement are measure, improve, measure, repeat. And the other one is thou shalt not decrease clinic productivity. And the same is true for community supports and for ECM, no doubt. And I'm really sorry, but I meant to pause and just ask if there were any questions about PDSAs before we move on to our deep dive into data. All right, I'd say that's a long enough pause. Raise your hand or type into chat, and Maria or Berenice will interrupt me. So moving on to the next slide, there's the three phases of performance measurement, aka data. So there's data for improvement, there's data for accountability, and there's data for research. And I just want to stress again that when we're talking about quality improvement, it's truly about improvement, not accountability. Although it's really hard when you present data that is by person or by team or by organization for them not to feel as though it is data for accountability. So I have to be honest about that. And at my clinic, as I mentioned, I implemented our electronic health record in 2005, and by 2006, 2007, we were posting reports on how the team, and we decided not to do it by provider. So before we had our electronic health record, and before we really leaned into quality improvement, we would give people their kind of reports on their performance with their patients or their patient panels in these little envelopes that were sealed that we stuck in their inbox. And then we decided to just say, we're going to share our data transparently with everyone. And I, as the quality coordinator, said, oh, no, I can't do that. Like, everyone's going to be so mad. They're going to tell me that they can't be responsible for what their patients do. They're going to tell me I can't, our workflows are terrible and the data reflects terrible workflows. And our director was like, I don't care, Trudy. We're all in this together. We're a team. If we have crappy workflows, then we need to figure out how to fix it. So I started putting data on our data board, and I did it by team so that people would not feel that sense of accountability. So I will say that one of my clinics shared data transparently, one of my practices in Boston. And because of the way they presented, what they called was QI data, they actually had 2 physicians quit, which was devastating. There's another way of presenting data. It's called a funnel diagram, which I've never used, but one of my practices used a funnel diagram, and it really sorts, like, who's doing the best, who's doing the worst. So I don't recommend using funnel data, using funnel diagrams. So let's go to the next slide. So when you're collecting data, explicitly state the questions that you want to be answered by the data. And these are questions that I used to ask as a clinician as well. When I would think about ordering a test on a patient, I would say, what is my question? Will the test answer the question? And will I do anything with the results? And if the answer is like, are we going to do anything with the results? No. Then I would wonder, do I really need to do this test? And getting data is like getting a test. So what exactly is our question? What percent of our members who receive our food or our meals are satisfied or highly satisfied? Will the data answer the question if you're administering a survey? Yes. Are we going to do anything with the results? Heck yeah. We're going to find out what is working so well for those people who are satisfied or very satisfied, and we're going to find out for those who are not satisfied, what in the world are we doing wrong and how can we do better? So always think about these 3 questions. I had a clinician who said, Trudy, I want to know how many of my patients that have upper respiratory infections that I send to the hospital receive antibiotics within the recommended time frame. I'm like, okay, that's great. I can get that data, but then what are you going to do with the results? And she said, yeah, I just want to know. I'm like, yeah, I'm not going to get that data. So, there's enough for us to do in a day. So, just think about the answers to those questions and use sampling to collect data just enough. If you have to do a random sampling, like the first 10 or 20, like, you don't need to do the entire target population. Because if you get stuck with, oh my gosh, I need to collect all this data, it's going to take me 8 hours to pull together and collate, you're just going to say, skip it. I'm not going to be collecting data. And design and test some sort of form for collecting the data if possible. Train those people who are going to collect the data and give them understandable instruction and record kind of what goes wrong during the data collection. I'm not going to dive into each of those. That could take me like an hour, but let's just move on to the next slide. And I know this sounds like a really easy question. What is data? It's kind of like, duh. So it's a measure. So whether you have a measuring tape, literally, and you're looking at how many inches something is, a measure, some sort of a measure, a count, how many, pass, fail, rating, 1 to 5, are all examples of data. We need data to learn. It's information and it comes in many forms. So remember when I was telling you yesterday that when I learned about data quality improvement, running reports, that I felt like Johnny Five from Short Circuit, somebody opened the door and I saw, input. So it's information and input, and it comes in many, many, many forms. So let's go to the next slide. So surveys, reports, hash marks, a whiteboard, simple counts, questions, data entry into the EHR dashboards, show of hands. I do this all the time, like in trainings, like how many of you, show of hands. How many of you are feeling great today? Give me a thumbs up for awesome. Give me a thumbs down for it's a crappy day. Give me a wiggly thumb in the middle for, it's okay. Meh. So there are all kinds of ways to collect data. And I skipped jar with stones because I wanted to tell you that story. So when I was on this project in Boston, I actually went to the offices of IHI, and because we were on the project with them, and they would have different questions at the reception desk, and it would be something like, "Are you having a good day? Yes or no?" And you would put stones in a jar for yes or stones in a jar for no. And at the end of the day, they could tell, oh, well, like in general, people were really, really happy. We have a lot of stones in the jar, in the yes jar. So let's go to the next slide. I just want to cover really quickly on surveys. So if you're developing a survey, we are happy to help you with that. As you know, Intrepid Ascent is delivering a survey, and they gave us the opportunity to kind of review it and give some feedback, which was really nice. We really appreciated that. But just think about what is the question? Will the data answer the question? What will we do with the results? For me, when I'm doing online training similar to this, and I want to know feedback on how did I do? I just like, great, I learned something new, good, it was decent, or not good, wish I hadn't wasted my time. So I hope that's not the case for you today. And then I want to make sure they learned something new. And then more than anything, I want to know what we could have done better. So just whenever you're doing surveys, I read surveys a lot, and people are like, oh, we're going to be doing this survey. Let's gather this other piece of information, this other piece of information, this other piece of information. Before you know it, you have this survey that takes people a half hour. They get to the third question and they see, oh, you're 5% done, and they're done with your survey. So let's move on from surveys. So data to drive improvement and to identify goals. So there you see that QI mantra of measure, improve, measure. So data drives setting aims and goals. So remember yesterday we worked on those aim statements, and I had you kind of trial putting in a SMART aim into chat. Well, it's really hard to ask you to do a SMART aim if you don't know what your baseline is. So a lot of times kind of where you're going to start and where you want to go, because you have to get your baseline. So you get your baseline. And this is also a potent tool to go to leadership to say why things need to change. Like, hey, only 15% of our only 15% of our ECM patients are taking their medications as directed. So it helps identify if a change is an improvement. It tracks progress over time. So we'll talk a little bit about how you do that. It supports sustain and spread, as I mentioned, and it identifies problems. So anything that is related to quality, equity, safety, efficiency, cost, patient experience, or work life of staff, AKA the quadruple aim, which we can talk about another time if you like, helps identify problems in all of those areas. And it creates the argument for change. Like, oh my gosh, I had no idea that we were, that we had so many opportunities to improve. And again, it creates the argument for change. Let's move on. So remember yesterday I mentioned we were going to cover measures, outcome, process, balancing, qualitative and quantitative. And if we were in a room altogether, I would look for a show of hands and say, can somebody describe outcome process, balancing measures, and the difference between qualitative and quantitative? But I'm going to go ahead and run through them super duper quickly. So outcome measures are truly, what is an outcome? A process measure supports an outcome. Usually you'll have an outcome measure and you'll have a process measure that identifies how well are we doing whatever it is to ensure that we have the desired outcome. Managed care plans care about outcome measures. So an example of an outcome measure is what % of patients with diabetes are uncontrolled and have an A1C of greater than 9%. So that's a HEDIS measure. That's also a care-based initiative measure. A process measure would be what % of our patients have had an A1C completed in the past 3 months. And then a balancing measure is if we're paying attention to this, like, are we not paying attention to that? So some practices will work on improving colorectal cancer screening, and they're paying so much attention to that they're not paying attention to breast cancer screening. So having a balancing measure helps ensure that you're not taking your eye off of a certain ball that you shouldn't. And qualitative and quantitative confuse people all the time, and confuse me. I sometimes mess up the descriptions when I try to explain them. So quantitative, think about quantity, and qualitative, think about quality. So quantitative is a count. Qualitative is something like a patient satisfaction survey. What was the quality of the care that you received? On our next slide, I have additional examples of outcome process and balance measures. And they are from primary care. I don't know the data and measures that we should be getting for community supports and ECM well enough to come up with examples that are outcome process and balancing. So for a community supports food or meals provider, a patient that is looking to lose weight, for example, if they actually lose weight, that's an outcome measure. A process measure might be the % of time that we deliver meals that are 1,500 calories or less, or something like that. So if those on the call have good examples, please feel free to chime in. There are tips for sharing data. I think what I'm going to do is just, skip this slide and let you read it when we send out our slides. There are methods to display data. I often say, I know that I'm in an organization that applies QI principles when I see data on the walls. I happen to be at one of our Santa Cruz organizations, and I was like so excited. I'm like, oh, you have data on the walls. And I looked at the data. I'm like, but that's from 2 years ago. But I love seeing data on the walls. I love seeing data in the waiting room or sharing it with your patients, whether you're a community sports provider or an ECM provider. So there are a lot of ways to graphically display data. My favorite is the red chart. I think it's just a little more easily to tell the story. So let's go to the next slide. So here's an example of a run chart, and it shows how things are going over time. So this practice was working on reducing their visit cycle time for a telehealth visit. And let's go to the next slide. You can annotate those. So you can see that for this clinic, They saw an increase in colorectal cancer screening because they did a test of change, they did a PDSA, they trialed it, they decided to adopt the pre-visit planning, and you can see that they had positive results. And it tells the story. So if you have just data in an Excel spreadsheet, you can't tell the story. And I would tell you a story about telling the story, but I see that we are now with 8 minutes left in our hour. So I'm just gonna cover the run chart a little bit. So let's go to the next slide. So run chart rules. So you see how run charts kind of go up and down and up and down. And, how do you know whether in a run chart, if you're watching the data, you're like, okay, so it's going up, but is that just because it's just kind of random variation, or is it because of something that we actually did? So a run chart, I'll spare you the statistical pieces of a run chart and knowing whether you can determine common cause or assignable cause, like, hey, it's because, we had floods and so vaccine rates went down or something like that. And there are rules that can trigger, but I truly am going to see everybody drop off if I launch into that. So let's go to the next slide. So it lets you know whether there's kind of instability in the process, which can be, you're just chaotic, you don't have standardization, or you can have catastrophes, breakdowns, accidents, personnel issues, like you just lost 3 of your ECM providers, or just kind of entropy, kind of how things go, or best yet, intentional changes. So we have covered so much information, so PDSAs and data, and we've done just top of the surface, hopefully to whet your appetite about quality improvement and PDSAs and data. And I'm going to pause now because we have about 6 minutes to see if there are any questions or comments. Oh, wait, did I just hear a snore? Just kidding. All right, so let's go to our next slide. So this is it for today. But as I said, we truly touched the surface. As we've mentioned, when we do this in person, we like to do it with like a 6 or 7 hour workshop where you're embedded in working the tools and getting feedback. And we delivered this training back in 2017, I think, and the Watsonville Health Center was working on reducing readmissions. They did a project charter, they did an aim statement, they listed out their tests of change, they even made a driver diagram, they implemented a bunch of their changes, and after things had time to settle in, the Alliance contacted me and said, what did you do? Like, they've actually reduced readmissions. I'm like, hey, I did nothing. They did all the work. But what they did is they took these principles and they truly kind of doubled down on using them to organize the work and make changes that were sustainable and meaningful. And readmissions for me is a huge thing. I used to work on an inpatient service, and part of the reason why they even hired me was to make sure that we did not have readmissions, and also to cut down on resident hours. But readmissions are terrible for hospitals because they get dinged, because it's very expensive. But who it really is terrible for is the patient. So it is meaningful work, and just an example of how these principles have worked in your community. And to close, let's go to our final slide. So tomorrow, we're going to do process mapping and then talk a little about QI strategy basics. So if you're listening and you're like, well, sure, yeah, let's build a QI strategy at our organization. Like, what measures are we going to look at? Like, what are meaningful measures? How can we collect them? How do we engage in improvement? There's actually one slide on QI strategy. It's basically like a little assessment that you can think about as we meet tomorrow. And then, we're happy to meet with you as well to take a deeper dive. And with that, I want to thank you so much for being patient with us today. We got through a lot of material with a couple of other challenges, which we won't even share with you. That's all good.
Thank you, Trudy.
Thank you.
Thank you.